So we have our next speaker today. I would like to invite Dr. Vijaya Govindaraj to discuss on the beyond the classroom innovative ways of learning for the next session. Welcome, sir.
How a tongue-based AP AP collapse could look like. So that posteriorly is what you see the tongue base, and it is coming and collapsing in an anteroposterior way. Last one, an example of how a tongue lateral collapse would. So epiglottis per se is not collapsing. If I'm going a further bit deeper, you will be able to see that. But the epiglottis is getting folded by the hyperpharyngeal collapse, which is more lateral. So why do we do all this? The present concept is that we can actually arrive at what we call as DICE phenotyping. It reveals dynamic and real-time airway collapse patterns, as we just saw. By phenotyping the collapse sites and patterns, DICE allows us for precise multi-level surgical planning. With the arrival of AI-assisted DICE, scoring, phenotyping has become more consistent and objective and accessible even in non-tertiary centers. But finally, what is the ultimate goal? That is to move from one-size-fits-all approach into a personalized, targeted intervention, improving both patient outcomes and the surgeon's confidence also. So a bit of a literature support for the same thing. All of these are 3 landmark studies which describes a lot. Interested people can have a read. So what's on table for the tongue base? In my practice, I have been using both coblation and RF ablation with nearly similar result. Coblation scoring a bit better than the RF at times, but most studies, landmark studies, I have not published or on this particular topic, but the landmark studies are clearly suggesting that coblation has a significant edge over the RF. And there comes the transoral robotic surgery, hypoglossal nerve stimulation, and also the genioglossus advancement. So epiglottis, again, it's based on the pattern, trapdoor floppy and lateral omega, which we just happened to see. Some of the minimally invasive techniques is epiglottis stiffening, partial epiglotectomy, and epiglottopexy. The epiglottis stiffening operation is a cartilage sparing procedure that stabilizes the epiglottis while preserving the protective function. Partial epiglotectomy effectively relieves trapdoor type collapse, especially for a trapdoor type collapse. In a bulky or a retroflexed epiglottis with low risk of aspiration when performed conservatively. Epiglottopexy includes suture suspension techniques, is increasingly favored for lateral or anteroposterior epiglottic collapse, offering reversible and function-preserving control. So one has to combine smartly, especially in a multi-level obstruction scenario. It definitely gives the surgeon a chance of a good success rate. I'm a Kamal Hassan fan, so this particular analogy that I take to explain goes like this. Most Tamil people here would have seen this movie Vikram. So I consider this palatal surgery as Kamal Hassan, the lead role in the movie, but the mission will fail without tongue-based interventions, which is Fahad Fasil, and epiglottic control, which is Vijay Sethupathi in the movie. So, no matter how skilled the lead palatal surgery could be performed, if that alone is performed, ignoring the hypopharyngeal collapse, then that's how it leads to a 40 to 60% of surgical failures. So these are some of the key developments which came up during my research in 2024-25 period. They are now calling it a low temperature coblation procedures which offer less pain, faster recovery. Robotic epiglottoplasty, which ensures precise handling in deeper airways. Suture suspension and epiglottis stiffening exercises, operations, which results in a function preserving epiglottis control. And DICE, they have included AI in it. I'm yet to have a hang of it, but it is supposed to remove the subjective observations which normally can have an interpretive fault from the surgeon's side. Hypoglossal nerve stimulation, it is yet to be popularized in our country. Some of the other recent technological innovations in OSA surgeries, this one got my attention. They're calling it the nomogram from CT scans. Including me, for the ones who doesn't know about it, is a visual predictive tool, a sort of graphical calculator that combines multiple variables like BMI, tonsil size, AHI, tongue base thickness, and CT scan findings of the airway width. Clinicians use it to personalize decision making. For instance, a nomogram might tell you that a patient with high BMI, large tonsils, and a REM predominant OSA has a 78% predicted success rate with a multi-level surgery. So when you treat the patient right, the patient sleeps right. And thank you. So this is something Dr. Vijay, Dr. Srinivas Kishore, everybody, they're all here. So seeing them is how I developed interest in sleep surgery. So we as a big team are organizing this in Mumbai coming up. Hope the sleep enthusiasts here show some interest in this and be a part of it also. Thank you.
Thank you, Dr. Karthik Made, sir. It's an excellent presentation. As sir told an analogy also about Vikram. It's very good, sir. So the take-home point is with hypopharynx, we have to combine with the tongue base.
Correct.
Thank you.
So hypopharynx, so DICE forms the crux
Basis.
of what you want to do with hypopharynx. And once when you see a hypopharyngeal collapse, it becomes almost a kind of a negligence on the part of the surgeon to ignore that collapse and not to do anything about it. Thank you.
Thank you. Thank you, sir.
Thank you, sir. We'll have our next speaker for the day. I invite Dr. Saktesh for the next session.
I think we are having an exciting day of OSA surgeries and all. So, many congratulations before I start. Many congratulations, Shankar. Where is he? Fantastic job. Let us all give him a big round of applause. So, I still vividly remember him calling me 1 year before, Sir, enna pannalam OSA, I am interested. And to see him organize such a big conference is a fantastic thing. And it's even more proud because he comes from the same pasare as me. Same Shankar Narayan sir, Suresh sir, Anthony sir. So, ஒரே ஒரு தலைவர் தான். So, same தலைவர், Anthony sir. And we are all his fans. So, it's good to see him organizing. So, I wish him all success.
Gave a real scientific presentation.
He
was
has made my job lot easier.
Yeah.
Shankar wanted, this was a 1 hour presentation which I made in MMC. Suresh sir was telling me. So, Shankar wanted me to finish it with 15 minutes. So, I'll just cover the relevant points. It's a good thing that the previous speaker actually covered part of my job. So, he's made my job easier.
Yeah, he said DICE brought science to snore, and he has brought science to this floor. He gave a lot of references, latest journal presentations. That was a real nice presentation, Karthik. Sakti said he comes from some Pasare. We were all trained in the same Pasare. We are not the Pasare, we are all trained in the same Pasare.
We were trained by you.
We were all students. We were a little senior student before you. We all come from the same place. I also take the opportunity to congratulate Shankar Subramaniam for this wonderful program. In this part of Tamil Nadu, I see a lot of my friends coming from Salem, Dharmaburi, Kalakurchi, Vellore, and I think many other places. It's a nice thing he brought all of us here. Thank you, Shankar.
So when we talk about OSA, so these are the common questions that people ask. So which is the most effective surgery in OSA? Can anyone answer? A lot of PGs here. So we have been seeing all surgeries, listening to all lectures. Which is the most effective surgery? Yeah, of course. But you can't do tracheostomy it's not going to be socially acceptable. And then, which is the most difficult to do procedure in OSA? So, I think these questions are irrelevant because OSA is a multifactorial problem. There is no place for ego in OSA treatment. So, you have to understand what's happening. You have to customize the treatment for each and every patient of yours. So, if not, you're going to burn your fingers bad. See, most of the OSA procedures, they're not as complicated as skull-based procedures or endo-ear procedures. But the most important thing that you have to understand is the final question, which is the important factor which decides proper treatment outcome in OSA. This is the most important thing. If you select your patient right, the outcome will be good. If you select the patient wrong, it's not going to be that pleasant experience for all of us here. So, it is important that in OSA I always say the evaluation is more important than the treatment. So, we need a tool which we can rely upon to predict what kind of treatment will suit these patients. So, remember, by treatment I am not saying just about surgery. So, it can be a holistic management. There is no concept like surgery versus CPAP now. So, it can be, many a times we do surgery to optimize CPAP outcomes. That we have long past that phase where we were just having an argument with pulmonologists about whether CPAP is better or surgery is better. So, now we are in an era of holistic management. So, we need the proper tools to make the proper diagnosis, and that is where DICE comes in. So, as we are getting the screen up, so we'll just discuss the things. I don't think I need a PowerPoint for this. To go into a little bit about the history. So, it all started like people wanted to know what is happening in the upper airway, which seems to be the site of obstructive sleep apnea. People wanted to know what is happening inside it while the patient is sleeping. So, early on people tried awake endoscopy, natural sleep endoscopy. It was called NSE. So, then it was not practically possible with those equipments because initially people were doing sleep endoscopy with bronchoscopes. Now, the scopes that we are using is 2.5 mm. Those scopes used to be 6 mm, 8 mm. So, imagine a patient having to put some endoscope which is measuring 8 mm while having a natural sleep. It is practically impossible. Then they understood that there needs to be some sedation to put the patient to sleep, and that's how drug-induced sleep endoscopy came into being. So, that's a little bit about the history. So, let me introduce about this concept which I call as DICE polygraphy. DICE, I think most of you would be aware, drug-induced sleep endoscopy, where you give some sedation, put in a scope and see what's happening inside. But then, this polygraphy is a term that we are all familiar. Polygraphy, it simply means that monitoring multiple parameters at the same time. So, when you combine these two things, drug-induced sleep endoscopy and polygraphy, you get what I call as the younger generation will understand. I would like to prefer to call it as the DP of an OSA patient. So, it gives you a lot of information into understanding what is happening with the patient and what we can do to make things better for this patient. So, like I explained, it is the simultaneous recording of both the endoscopy and the multiple physiological parameters together. So, indications, I would rather say it should be done in all patients who are diagnosed with obstructive sleep apnea without any exclusion. And it is more important where you are considering some alternative for positive airway pressure treatments. Then you can understand what is the reason behind the failure, why the patient is not responding to PAP therapy, why the patient is not responding to the oral appliance therapy. These are the other indications. And like I said before, we don't do surgery to replace CPAP. Sometimes we do surgeries to augment the effectiveness of CPAP. So that is another indication. And surgical failures. So it allows us to understand why a particular surgery has failed in that particular patient. So contraindication, there's only this poor anesthetic risk patient, and pregnancy is another patient where you would avoid it. Relative morbid obesity, you just have to follow precautions, that's all. So I think that time also includes the screen down times, I guess. So these are the minimum equipments. Of course, you need to have an endoscopy setup. You need to have a BIS monitor to assess the sedation, and also the patient monitor that we all use in all the anesthetic procedures. So drugs, basically, I'll just give you an overview. There are 3 drugs basically: propofol, midazolam, Dexmed. Dexmed we no longer prefer because the sedation induced by Dexmed is not consistent. Sometimes the patient goes so deep, sometimes the patient is very superficial, so you cannot predictably judge, and it's a longer acting agent, so it's not preferred. So that leaves us with 2 drugs, propofol and midazolam. Propofol, very fast acting, produces lesser respiratory discomfort. Midas gives you a longer window of observation, but it can cause respiratory depression. So in my place, we prefer to use propofol. That's what my anesthetist prefers. And this is the setup that we use for DICE polography. This is not a medical equipment. This is an equipment that is used by a lot of videographers and camera people. This is basically, it allows 2 video inputs to be put inside the device, and it will give a fused video. So just remember that. And this is the overall setup. So you have that recording equipment here, and you have this endoscopy equipment monitor here, and this is the laptop where everything gets recorded. So this is an external monitor which records what happens to the patient externally. This is very important if you ask me. You know, if you just imagine just looking inside what is happening, outside the patient may have his mouth open, his jaw may be falling forward. Having that information gives you crucial insights. So we have an external camera recording the thing. And finally, you have this vital parameters which are being recorded as a separate video. So this, and also we have a microphone attached to both the patient and the surgeon, so that you can record the snoring, and as well as the surgeon can provide his live inputs as well. So this is the software which integrates everything together. So when you come to the staff, you have the surgeon, of course, the anesthetist, who I think is the most important person in the team, because a good anesthetist can make or break a DICE procedure. So it is important to have an anesthetist who understands the procedure and knows what we are looking out for. And then you have a technician who helps you with all the procedures and other things that we do. So sedation monitoring, there are basically 2 ways to do it. Both are important. One is BIS, bispectral index, and it is not a holy grail. We have seen patients who have been deep asleep even at BIS values of 90. And we have had patients who have been wide awake even at BIS value 40. So BIS is only a guide. And the other thing which we have to correlate, this is the BIS monitor. So it gives you a number. So ideally, we would like to do an ideal plane will be between 50 to 75 is the ideal plane, but it is only a reference. But of course, you have to correlate clinically. This is modified Ramsay sedation score. This is widely used by anesthetists. You have to correlate with this also to get an accurate picture of how deep the patient is sedated. And then when it comes to observation, always do an awake scopy. Do an awake, complete awake upper airway scopy, then ask your anesthetist to start the sedation. This is very, very important. Then you wait for the first cycle of apnea snore to end. Then you start your observation from the second cycle. You do your observation at 3 levels, the velum, oropharynx, and the tongue and epiglottis. For the velum, you place the scope at the tip of the posterior end of the nasal septum. For the oropharynx, you keep it at just beyond that point, and then when you go to the epiglottis, just at the end of the free edge of the soft palate. So you have to do it in different position. If your polysomnography tells that the patient is having a positional variation in AHI, And you can do procedures like jaw thrust, mouth closure, and even if you want, you can put a CPAP while the patient is on DICE and see how the CPAP will or will not help the patient. And you can also use oral appliances therapy while you're doing the endoscopy. So reporting is the standard word to avoid confusion so that there is standardization. So at each level you have to say what is the orientation, whether it's a complete collapse or a partial collapse. And this is how the reporting would look like. So imagine if I just give you this center endoscope, that's not going to give you much information. So here you have what is the BIS of the patient, what is happening to the SpO2, what is happening to the heart rate, what is happening to the ECG, and what is happening externally. So it gives, when you pass the video at any point of time, you are getting a complete whole lot of information about what is happening to this patient. And of course, that's going to make our job easier when we are going to planning the treatment. So like I said, it opens up a lot of possibilities. It makes a qualitative study, a combined qualitative and semi-quantitative study. What you can do with DICE, you can confirm the polysomnography findings. I mean, DICE polygraphy, you can judge whether what is reflected in the sometimes we have level 3 polysomnography. Recently we had a patient who had a very mild sleep apnea, but the only thing which was sticking out was his heart rate variations. His heart rate variations were abnormally high. So when we did DICE, we found out that it is only an observational error. So that is something you can do. You can understand the endotypes, what is happening to the patient. You can decide whether the patient will be a suitable candidate for surgery or CPAP or a combined treatment. And finally, the final thing is very important, identifying the no-go patient from it is like having a trial before you give actual anesthesia. Doing a DICE is like doing a trials. You know how the patient is going to behave when you are giving anesthesia. So thereby you can do this. If we have time for this, where is Shankar? We can play the video, otherwise we can skip it on. This is just, I would like to say, you might have seen all the collapse and other things. I would like to play only this thing, because many a times there is one accusation made against DICE is that it is not a natural sleep. So this is a patient with normal AHI whom we did DICE because the parents were insisting that they want to understand why the guy is feeling sleepy. So this is the DICE on a normal patient. So you can see the value 61 is the BIS value. So that means that the patient is at the right plane. So, but then you can see the entire airway is beautifully open. There is no collapse anywhere, and there is no room for these allegations that there is a drug-induced collapse here. So in a normal patient, it reflects what normally would happen in a patient sleeping. So this is something that I would like to show. Simple snoring, you will see that only there is collapse, vibration, but there is no complete collapse. And when you go to sleep apnea, there is complete collapse. There is no space at all. So I think you are able to appreciate the difference. The previous video, there was only vibration. There was not complete airway closure. Here you have a complete airway closure. These things I think you might have seen. Salpingopharyngeal folds collapsing, infantile epiglottis which is collapsing. Arytenoids can sometimes collapse. Usually this is secondary to an upstream collapse, but sometimes it could be primary as well. So, and finally, before I close, these are the words of caution. Always don't take it as a diagnostic procedure. See it like a procedure, because these OSA patients are bad airway patients, bad anesthesia risk patient. Always do it in a theater setup. Never try to do it in a minor OT or in a OP setup. Like I said, anesthetist is the most important person. We are just putting in the scope and seeing he is doing all the important work. So always have a good anesthetist. And this is another important thing. Always take intubation and ICU admission consent, because we have had one patient. See, we just see it as a diagnostic procedure. Generally, the patient comes in 2 hours before the procedures, walks out 2 hours after the procedure. One patient completely desaturated. We had to intubate him, put him in ICU. Problem was we had not talked about it, we had not taken consent. So it's going to put you in a very bad situation. So always take consent for intubation and ICU admission, and always be prepared to handle a airway crisis when you do this. And finally, DICE is only a snapshot of the patient's OSA. Understanding the patients from a broader perspective cannot be understated, because the concept of current management of OSA is holistic, not surgery, not CPAP, not anything in single thing. It is a combination of things. With that, thank you for the opportunity. Sorry, Shankar, I took a little bit of.
Thank you, sir. It's an amazing presentation. From desktop picture to dice polygraphy. So when we hear the word DP, hereafter we'll be remembering only dice polygraphy.
Thank you.
Sir. Thank you.
Thank you.
Yeah, congratulations, Saktish. That was a really good presentation. We know that you are a very smart person with a keen observation and a good person in making choices. We know that from the way you chose your partner long back, and you chose this as your subspecialty.
So that also came from MMC, sir.
Yeah,
I
I
got
know
a lot
that.
of good things from MMC.
Both of you, in a way, was our student. Okay, so you chose sleep as your subspecialty, and you picked up this new thing. You are telling us. We were telling polysomnography was one of gold standard some time back. Then many things changed. Probably now dies with polysomnography.
Sir,
Dice
everything is
polygraphy.
important, sir. Everything is important in the particular patient,
yeah.
sir.
Yeah, good. Thank you.
Thank you, sir. Thank you.